So the second part of today's talk looks at first-line regimens. I include this only for reference. You've already done the online learning module, no doubt, and you will have seen the animation that looks at the HIV viral life cycle. And I think it's important not only because it shows the viral life cycle, but it also shows the steps within the viral life cycle where each of the antiretroviral drug classes actually works. The following slides explain each of the drug classes and where they work also. So I invite you to pause the video briefly and to familiarise yourself with the following slides, looking at each of the individual drug classes and where they work within the HIV viral life cycle. So this table lists the classes of antiretroviral therapy, and there's some common abbreviations. So the NRTIs, or the nucleoside reverse transcriptase inhibitors, common drugs in this class include lamivudine, or 3TC, emtricitabine, or FTC, tenofovir. Now, tenofovir has a number of salts or formulations. So TDF was the older one that we used previously, and it's in Truvada, which has been used for PrEP or pre-exposure prophylaxis. Tenofovir disoproxyl fumarate, or TDF, has two bioequivalent salts, malleate and phosphate. So TDF, TDM, and TDP are bioequivalents. Tenofovir alafenamide, or TAF, is a different type of tenofovir, which is processed in the body in a different way. There is a lower concentration of the active form of tenofovir in the blood, but a significantly greater form of the active tenofovir gets its way into the CD4 cell. And I'll explain shortly why that's important. In terms of other NRTIs, abacavir and zidovudine are two others. The next group are the non-nucleoside reverse transcriptase inhibitors, or NNRTIs. So common drugs in this class are efavirenz, rilpivirine, nevirapine, and etravirine. Increasingly, people on these regimens, they're no longer initiated in most people living with HIV now, and increasingly individuals are being switched off these regimens. So they're not common drugs used to treat HIV in this era. Protease inhibitors, common protease inhibitors include atazanavir and darunavir. Previously, we used a single pill combination of lopinavir, ritonavir, or Kaletra. Very uncommon to use that now. One of the newer classes of drugs which has gained significant popularity in the last decade are the integrase inhibitors. So common integrase inhibitors are called bictegravir, dolutegravir, alvitegravir, and raltegravir, and we'll talk about each of those individually shortly. Enfuvirtide is a fusion inhibitor, a drug that's administered subcutaneously that is rarely used in 2020. And Maraviroc is a CCR5 inhibitor, or it's a type of entry inhibitor, which is also no longer commonly used. Now, we have a number of fixed dose combinations in HIV medicine. So these on this slide are 3 and 4 drug fixed dose combinations in a single pill. So if we look at the first column, we've got multiple NRTIs with an integrase inhibitor in one pill. The two there are Triumec, which is a fixed dose combination of abacavir, lamivudine, and dolutegravir. And then we have Biktarvy, which is a fixed dose combination of tenofovir alafenamide with FTC and bictegravir. In terms of multiple NRTIs and a cobicistat boosted integrase inhibitor, we have Genvoya, the ingredients of which you can see by looking at the footnotes below. Simtuza is a single pill containing multiple NRTIs with a cobicistat boosted protease inhibitor, which was PBS listed for use in Australia on the 1st of April this year. And finally, in terms of multiple NRTI and NNRTI combination single pills, we have Atripla and Odefsey. And again, the ingredients of those are shown on the slide below. We also have a number of fixed dose combinations that only contain 2 drugs. So most of these are usually used in combination with a third drug. For example, Descovy, Truvada, Kyvexa would be used with a third drug. But over the course of recent years, dual therapy, both in the treatment-naive setting and in the switch setting, is becoming more popular based on increasing robust evidence supporting its use. And so if you look at the first column there, you've got a number of NRTIs, which we call the so-called backbones, Descovy, Truvada, Kyvexa and Combivir, and you can look at the ingredients of each of those single pills at the bottom there. Now, in the second column, we've got Dovato. So Dovato is a single pill that contains the NRTI lamivudine, or 3-TC, in combination with the integrase inhibitor dolutegravir. And that's called Dovato, and that has been, it's indicated in Australia, so it's PBS reimbursed for treatment-naive individuals living with HIV. So it's a dual therapy rather than a triple therapy regimen that can be used for treatment-naive patients in Australia. In the third column, we've got protease inhibitors in fixed-dose combinations, Evirtaz, Prescribix and Kaletra. And in the final column, we've got an NNRTI integrase single-pill combination called Juluca. So Juluca is one pill which contains dolutegravir, the integrase inhibitor, along with the NNRTI rilpivirine, and that is PBS reimbursed in Australia for patients switching therapy, not treatment-naive individuals. So antiretroviral therapy is a combination of drugs from different drug classes, and it's a total of 2 or 3 different HIV drugs from 2 different drug classes. Usually there's either 1 or 2 NRTIs in combination with a drug from an additional class. And we'll now take a look at how to choose from the various HIV drugs to create the right regimen for your patient. We'll also talk about some common combinations, some of the common toxicities, and it's really important to know about these when you're tailoring a regimen to the person sitting in front of you. And it's really important to also consider factors which would have an impact on medication adherence, as well as other comorbidities that your patient may have. So in terms of what options are recommended, in Australia, we have the ASHM treatment guidelines. They are based on the US Department of Health and Human Services HIV guidelines. So the American DHHS guidelines are updated several times a year, and shortly thereafter, the Australian Antiretroviral Guidelines Committee reviews the American guidelines and tailors them to the Australian context. And you can see the web link on this slide to both the Australian guidelines and also to the American DHHS guidelines also. We now talk about initial regimens for most people living with HIV, and then initial regimens in certain clinical situations. So this is looking at regimens to initiate on treatment-naive people living with HIV. And what you can see by and large is these drugs, or rather these regimens, are all based on the integrase inhibitor class of medications. So the first listed there is bictegravir, emtricitabine and tenofovir alafenamide. So this is a triple combination which is called Biktarvy. The second one listed there is dolutegravir, abacavir and lamivudine. And this is a triple combination single pill agent called Triamec. But it's important that, because it contains abacavir, that this is not initiated until one has had the HLA-B5701 testing completed and that test is negative. So those first 2 regimens are single pill regimens. The next one that's recommended is dolutegravir in 1 pill with a combination of emtricitabine with tenofovir. Now that can be TDF, TDM or TDP, but the older tenofovir salts, or TAF, tenofovir alafenamide, the newer tenofovir. So essentially we're talking about dolutegravir with either Truvada or Descovy. Similarly, raltegravir, another integrase inhibitor, in combination with the separate pill of either Truvada or Descovy. And more recently, we alluded to this earlier, is dual therapy. So there is a new fixed dose combination of two agents in one pill, which is called Dovato. And Dovato is a combination of dolutegravir and lamivudine in one pill. And this has been listed on the PBS in Australia for treatment of treatment-naive individuals with HIV, as long as a couple of requirements are met. So that individual should not have an HIV viral load greater than 5,000 copies per mil. They should not have hepatitis B co-infection, and Dovato, this dual combination, should not be initiated if that individual wants to start treatment or it needs to start treatment without the HIV resistance genotype result having returned from the lab. That test can take up to 3 weeks, and some individuals may choose to start earlier. And again, the guidelines, there's a link on the bottom of the screen to the Australian antiretroviral guidelines. In addition to those regimens we just discussed, which are the first-line regimens in most situations or for most people living with HIV, there are certain clinical situations where we might deviate from the first table, and we might need to choose other regimens specific to the characteristics of that individual living with HIV. So elvitegravir, cobicistat, emtricitabine, and tenofovir. So this is a combination. Originally, we had a medication called Stribild, and we now have Genvoya. And Genvoya is the version of the combination which contains TAF. Stribild has been delisted. So we've been using that as a first-line agent for some time. But because elvitegravir is considered to be a lower potency integrase inhibitor, and this combination contains a booster, namely cobicistat, it's considered to be less favourable than those listed on the previous slide. Similarly, a boosted protease inhibitor with two NRTIs, so darunavir boosted by cobicistat, or darunavir with ritonavir with emtricitabine and tenofovir as one option. And it's important to note that Simtuza is a single pill option that is a fixed dose combination of darunavir boosted by cobicistat with emtricitabine and tenofovir alafenamide or TAF. Atazanavir boosted by cobicistat or atazanavir boosted by ritonavir with emtricitabine and tenofovir is a regimen that we used to initiate with previously, which, if for whatever reason none of the other regimens were considered suitable, we could still use, but that would be an uncommon regimen to lead with in 2020. Darunavir boosted by cobicistat or darunavir boosted by ritonavir with the combination of abacavir, lamivudine, again used more commonly in the past, but could be used provided the individual's HLA B5701 test was negative. That would be unusual to be using that combination, however. The NNRTI-based regimens that you might consider in certain clinical situations would include efavirenz, TDF and FTC, or rilpivirine with tenofovir and FTC. Again, unlikely to use these in many clinical situations. I think rilpivirine with tenofovir disoproxyl fumarate along with FTC, that has actually been delisted from the PBS, but is available on compassionate access and might be considered in the context of pregnancy. When you can't use abacavir, tenofovir, or TAF, we have some evidence for other regimens which are not standard triple therapy regimens. The evidence for some of these regimens may be a little bit less robust. The first one, dolutegravir and lamivudine, we've actually talked about on the slide before this, Dovato, and we do have robust evidence for use of that in the treatment-naive individual setting. But other combinations, such as ritonavir-boosted darunavir with raltegravir, if an individual's viral load is less than 100,000, we do have, and their CD4 counts above 200, we do have some data there, bearing in mind that's a twice-daily regimen. And we also have some data for ritonavir-boosted darunavir with lamivudine. But these days, I think if we're unable to use abacavir or a tenofovir containing regimen, then dolutegravir lamivudine would be the most popular way to go. When you're looking specifically at choosing the first-line regimen, issues we consider are the potency of the regimen, tolerability and the toxicity of the regimen, and the pill burden. And, how easy is it to use? Is it once daily? Is it twice daily? Is there a food requirement? We also look at specific comorbidities an individual may have. For example, depression, hepatitis, co-infection. Are they elderly? We need to think about the drug-drug interactions. Acute HIV infection, that individual we may choose or they may choose to initiate therapy immediately without the without the HIV resistance drug, the HIV resistance genotype having returned from the lab. And they may choose to do that for a number of reasons. It might make them feel less symptomatic if they're suffering from severe seroconversion symptoms, or for that individual, it might be about taking control, starting treatment straight away. In any case, if an individual wishes to start treatment without a resistance genotype, the guidelines make specific recommendations about that particular clinical scenario. So although the standard combination has consisted of the backbone with 2 NRTIs and an anchor drug or a third drug, which for the last decade has largely been an integrase inhibitor, or at least the last 5 years has been an integrase inhibitor, it's important to realise that the most recent update of the antiretroviral guidelines in Australia now includes the first dual therapy regimen of dolutegravir of 3TC, which we mentioned earlier is called Dovato. So provided an individual has a baseline HIV viral load less than 500,000, they do not have hepatitis B co-infection, and we have their resistance genotype back, that dual therapy option could be considered along with the other first-line regimens. So looking at all those first-line regimens by way of their particular characteristics, Biktarvy, the combination of bictegravir, emtricitabine and TAF, is a single pill regimen, as is Triumeq, Genvoya and Dovato, and you can see their specific ingredients there. When you look at the first-line regimens by way of which include a booster, so either cobicistat or ritonavir, TAF, emtricitabine and elvitegravir boosted by cobicistat or Genvoya is there, along with Simtuza, which is the fixed-dose combination of TAF with emtricitabine and cobi-boosted darunavir. Darunavir boosted by ritonavir can also be used with either Truvada or Descovy. And then the latter, so use of either abacavir or tenofovir. I guess the question these days, or the issue these days, is abacavir is associated with increased risk of myocardial infarction. So the majority of regimens, at least prior to the advent of dual therapy with dolutegravir and 3TC, probably the majority of regimens would contain a tenofovir-containing medication. So, for your individual one-pill regimen, if you're choosing a one-pill regimen, the first step is to look at the backbone. So, emtricitabine or lamivudine, so FTC or 3TC, are basically one and the same. So, the regimen you would choose would contain one or the other, not both. So, emtricitabine, looking at characteristics of it, it's well tolerated, and it also is active against hepatitis B co-infection as well. But it has been associated with hepatitis B resistance if it's used as monotherapy. So if someone had hep B co-infection, you would want to ensure that they're on 2 drugs active against hepatitis B. Really, emtricitabine has been associated with skin discoloration, though I emphasise that is rare. Comparing emtricitabine to lamivudine, lamivudine is also well tolerated, also treats hepatitis B infection. Again, hepatitis B resistance develops if lamivudine is used as monotherapy. And so if an individual is infected with both HIV and hepatitis B, then more than one agent active against both viruses would be selected. Then looking at abacavir versus tenofovir. So the choice of either abacavir or tenofovir formulation So looking at the backbones in the traditional triple therapy regimen, you would either generally be taking abacavir or tenofovir. And the tenofovir would either be tenofovir alafenamide, which is the newer form of tenofovir, which has a better toxicity profile in terms of reduced toxicity to both kidney and bone. But comparing it, so tenofovir alafenamide is equivalent to tenofovir disoproxil fumarate and its associated salts, TDM and TDP. So essentially, TAF and TDF, or TDM, TDP, are different forms of tenofovir. So you would use one or the other form of tenofovir. So abacavir is well tolerated, provided the individual is HLA-B5701 negative. It's thought, though, that individuals with a baseline HIV viral load greater than 100,000 copies per mil, that it's potentially less robust and more virological failures were seen in the early phase 3 clinical trials looking at regimens containing abacavir, except when it was given with dolutegravir, and then this wasn't an issue. Abacavir is not active against hepatitis B, and so it isn't recommended if an individual has HIV hepatitis B co-infection. Also, abacavir, and this comes under the ugly heading, has an increased risk of cardiovascular events and of the nasty abacavir hypersensitivity reaction. So this is a multi-system reaction to abacavir, which can be fatal. We have the HLA-B5701 reaction, which reduces the likelihood of this occurring. So if an individual tests positive for HLA-B5701, we don't use abacavir. But being HLA-B5701 does not 100% exclude the risk of abacavir hypersensitivity. So if one is initiating a regimen containing abacavir, you always must be considering hypersensitivity if someone presents with symptoms. And one should never initiate abacavir without screening the HLA-B5701 test first. So then tenofovir disoproxil fumarate. So the older form of tenofovir versus the new one. What is the difference? So they're both prodrugs requiring conversion to the active drug. Plasma levels of the active drug of tenofovir, though, with TAF, the newer form, are 90% lower than they are with TDF, the older form of the salt, of the drug. But the intracellular concentration with TAF is many times higher than with TDF. So as a result, you get a lower dose of tenofovir alafenamide compared to tenofovir disoproxil fumarate is needed to suppress HIV. So the TAF comes in doses of 10 milligrams or 25 milligrams versus the TDF dose of 300 milligrams. So in summary, the concentration of the active tenofovir in the blood is significantly lower when one takes the TAF form of the drug, but the active drug within the CD4 cell is significantly higher. And the potential benefit of this is that given the concentration in the blood is much lower, you're likely to get much less off-target toxicity. So reduced kidney and bone toxicity, but you're getting active drug into the CD4 cell where you want to suppress HIV. And both TAF and TDF are available in fixed dose combinations. So what is the difference between TAF and TDF? In terms of their similarities, they both have the same activity against HIV and could be used interchangeably, and they both have similar activity against hepatitis B, so they can be used interchangeably there also. What about the differences between TAF and TDF? Well, in terms of TAF, there's different doses. So they're both co-formulated with emtricitabine in a single pill called Descovy. But when you're writing the Descovy prescription, you need to specify which strength of TAF you want. So TAF can be either 10 milligrams, Descovy can come as a 10 milligram formulation of TAF with emtricitabine, or a 25 milligram strength of TAF with emtricitabine. The lower dose is prescribed when the third drug in the regimen is boosted. So if you're using a regimen containing either cobicistat or ritonavir to boost your third agent, it's going to boost the TAF also. So you would prescribe Descovy, which contains the 10 milligram strength of TAF. If, on the other hand, you're prescribing an unboosted regimen, so for example, your third drug might be dolutegravir or bictegravir, neither of which require boosting by ritonavir or cobicistat, then you use the higher strength of TAF. So you would use 25 milligrams of TAF in the unboosted setting. The newer form of the newer form, or TAF, is thought to have lower renal and bone toxicity. It's noted that tenofovir has an impact on lipids, and that the older form, TDF, has a more favourable effect on the lipid profile than the newer form of TAF. But when you look at the total cholesterol HDL ratio, which is what we use to calculate cardiovascular risk, the ratios are preserved whether you prescribe TDF or TAF. There is also a potential for weight gain associated with TAF when it's initiated or when an individual switches to a TAF-containing regimen compared to TDF-containing regimens. And there are some subtle drug interactions. Drug interactions for tenofovir, disoproxil fumarate are minimal. But TAF, on the other hand, does have some clinically important and relevant drug-drug interactions, and these are largely to do with tuberculosis treatment and some anticonvulsants as well. So sometimes, and it's not appropriate for an individual to take a TAF-containing regimen because of other comorbidities or other medications. So when we compared TDF to TAF, let's start with TDF. So it's well tolerated and active against hepatitis B infection. So use it with another agent as dual therapy to cover Hep B co-infection. And it has a favourable lipid profile. We know that TAF reduces bone density and it can cause some renal dysfunction. And TDF has an effect on bone metabolism and causes some renal dysfunction. And so we don't like to use TDF if the eGFR falls below 60. And similarly, it can be associated with significant renal toxicity. Early on, it can cause acute tubular necrosis, and it's also been associated with chronic kidney disease and Fanconi syndrome. TAF, on the other hand, it's important to note that TAF is a significantly newer drug, and so we don't have the long-term safety data for TAF that we do with TDF, and it's something we are continuing to monitor. TAF is well tolerated, and like TDF, it's active against hepatitis B co-infection, and you would always use it with another drug that is active against Hep B. It has reduced or less of an impact on bone density and a more favourable renal side effect profile. And TAF can be used all the way down to an eGFR of 30. As discussed on the previous slide, TAF, on the other hand, has some drug-drug interactions that TDF does not. And it's thought that TAF may be associated with some possible weight gain, and that's a bit of a watch this space at the moment. In terms of the tenofovir formulations, TDF, the one we've been using for a longer period of time, comes at 300 milligrams, and its salts are bioequivalent. I won't spend much time. This is a reference slide, really, just for your understanding of the different types of tenofovir. It's important to note that for HIV treatment, the majority of people taking tenofovir for treatment will be on a TAF-containing treatment, either 10 if they're on a boosted regimen or 25 if they're on an unboosted regimen. But at the moment for PrEP, pre-exposure prophylaxis, that it is a TDF-containing regimen or TDM-TDP. But in Australia, TAF is not reimbursed as part of a pre-exposure prophylaxis containing regimen. So we've talked about the different characteristics of the NRTIs that make up the backbone. So when you're then choosing your NRTI backbone, if you're looking at a triple therapy regimen, it's important to think about a few points. Young people with no comorbidities or co-infections, probably doesn't matter which backbone you choose. So putting an individual with a very low cardiovascular risk on a bacavir, is probably a reasonable approach. However, in an individual who's got high cardiovascular risk or established cardiovascular risk, abacavir is clearly a drug to avoid. Similarly, if their HLA-B5701 test returns positive, you must absolutely avoid abacavir. And as I said earlier, mark it as an allergy on that individual's file. When we're looking at TAF versus TDF, we know that we've got TAF available as a fixed-dose combination with emtricitabine, and it's in a single pill with elvitegravir boosted by COVID, and that one's called Genvoya. It's largely replaced TDF, TAF, so there are very few people who take TDF as part of their treatment regimen. And if someone has baseline renal disease, talk to your mentor about it, because you may still choose, even though you can use TAF down to an eGFR of 30, you may still choose to avoid TAF, even though it has a better renal profile than TDF. When abacavir and TAF or TDF can't be used, what then? This is where Dovato should seriously be considered. So Dovato, we talked about earlier, was recently listed on the PBS for treatment-naive individuals. It's a dual therapy single pill combination that contains dolutegravir and 3-TC. There are some caveats to its use, though. It needs to only be initiated if the individual's baseline viral load is less than 500,000 copies per mil. They need to be hepatitis B negative, because it's only got 3-TC, one drug that's active against hepatitis B, and we want to make sure that they have no resistance on their baseline genotype. If the criteria for initiating Dovato are not met, then we're talking about a non-standard first-line regimen, and you really, really need to be talking to your mentor to look at what other options might be available for that individual. So then if you're choosing an integrase inhibitor, so that anchor or third drug, then we've got a few to choose from. There are 4, in fact, integrase inhibitors. So this slide compares dolutegravir, 50 milligrams once a day, or bictegravir, 50 milligrams once a day. They're very similar drugs. They're once a day. Dolutegravir is available as a single pill as well as co-formulated. It's co-formulated, in terms of co-formulations, dolutegravir is co-formulated with abacavir and 3-TC as Triumec, while bictegravir is co-formulated with TAF and FTC as Biktarvy. They both have very high potency, or they're both very high potency drugs, and they're both very well tolerated. They have a high barrier to resistance, and it's a higher barrier than either elvitegravir or raltegravir. There's no food requirement with these drugs. They tend not to have an impact on lipids, and they don't have any interactions with hormonal contraception. What's bad about them? They block a transporter in the proximal convoluted tubule where 10% of creatinine is excreted. Now, that's not harmful in its own right, but what it does is increases creatinine by 10%, which then, of course, we use creatinine to calculate the eGFR. So it causes a decrease in the eGFR, not a real decrease, but an artificial decrease in eGFR. So it's important to understand baseline eGFR before initiating somebody on either dolutegravir or bictegravir. And both of these drugs can have their absorption impaired if they're taken with metallic ion-containing medications, such as antacids, which might contain aluminium hydroxide, or multivitamins. So you need to be thinking about things like calcium, aluminium, and iron. And it's important, if an individual wants to take any of those medications or is, that they're dosed apart. So if they're dosed at the same time, those other agents can bind to and impair the absorption of dolutegravir and bictegravir. It's important to note, too, that they're both relatively new drugs. Dolutegravir was listed on the PBS in 2014 and bictegravir last year, 2019. And so we don't have long-term safety profile data that we do for a lot of other HIV medications. Drug-drug interactions are a significant consideration when it comes to these medications. So there are significant interactions with rifampicin, St. John's wort, and metformin. We know that dolutegravir blocks excretion of metformin and increases its concentration. So it's important to be aware of that and dose adjust the metformin. Neuropsychiatric side effects such as low mood and insomnia can occur, though they're considered rare. We've been concerned about the possibility of dolutegravir being taken at the time of conception being associated with neural tube defects. And that story is still being told. It's looking a little bit more favourable than when the signal was initially noted back in or reported in May of 2018, but it's watched this space. As for bictegravir in pregnancy and concerns around being on it at the time of conception, there is no data. We're also concerned about the possibility of weight gain associated with these integrase inhibitors in certain populations. So choosing the NRTI continued, this is the third integrase inhibitor, choosing the INSTI. The third integrase inhibitor we've got is elvitegravir, and that one is boosted by cobicistat. And so that's in a single pill along with TAF-FTC called Genvoya. Previously available, we had Stribil, which was essentially the same medication but contained TDF instead of the newer formulation of TAF. That's been delisted from the PBS recently also. TAF is good because it's a single pill, it's daily dosing. It does have a food requirement. It can be used when it contains TAF. It can be used with an EGFR down to 30, but it also blocks the proximal convoluted tubule transporter, so it causes that artificial increase in creatinine and subsequent drop in EGFR that we discussed with dolutegravir and bictegravir also. Co-administered with tenofovir, it can boost the effect of that tenofovir. So as we said earlier, it's no longer available as Stribil. So ultimately, it's only boosting TAF, and it's boosting TAF at the lower dose of 10 milligrams. So that point is less of an issue now. It can, again, have its absorption decreased with co-administration with polyvalent cation-containing medications, such as medications containing aluminium, calcium, and iron, as we discussed earlier. So same issue. You need to space the dosing of those medications and these integrase inhibitors, and it can cause an increase in lipids, as does the other booster ritonavir, but Cobi to a lesser degree than ritonavir. It's a lower barrier in terms of the ugliness of this drug. It has a lower barrier to resistance than boosted protease inhibitors or dolutegravir and bictegravir-based regimens. It is the perpetrator of some drug interactions as a booster because it inhibits the CYP3A4 enzymes. Rarely it has been associated with neuropsych side effects. And again, we're concerned about the potential for weight gain in certain populations. Raltegravir, the original integrase inhibitor, initially was 400 milligrams twice daily. Then we had a reformulated version, which is 600 milligram tablets, and they are taken 2 at the same time each day. So 600 milligram, 2 pills daily along with a backbone, or 400 milligrams twice daily. It's a well-tolerated lipid-neutral medication that doesn't have a food requirement and has no CYP3A4 interactions, and so no concerns regarding interactions with hormonal contraception. The older formulation, as I said, was twice daily dosing, and again, it has the same issue with decreased absorption with polyvalent cation-containing products. So dose those apart, obviously. What's really unfavourable about raltegravir, though, is its lower barrier to resistance compared to dolutegravir and bictegravir. It has been associated with myopathy when the creatine kinase measurements were normal, and rarely with rhabdomyolysis. And albeit rare, it has also been associated with severe hypersensitivity reactions and rarely with depression and suicidal ideation. Again, with all these integrase inhibitors, there's a potential for possible weight gain in certain populations, and ultimately that story is still being told. In terms of protease inhibitors as third drug options, this is less common, and in fact, for most people living with HIV, the integrase inhibitor would be considered the first, the only third drug, or in dual therapy, it would be dolutegravir. Looking at darunavir, 800 milligrams boosted by ritonavir, 100 milligrams, or darunavir boosted by cobicistat 150. It's a once daily medication that doesn't have any interactions with proton pump inhibitors, like its colleague atazanavir there, has a high barrier to resistance than other classes of medication. It can cause diarrhea, increased lipids, a rash, and there are food requirements associated with dolutegravir, and it can cause hepatitis as well. There are significant CYP3A4 drug interactions, and there is a concern about kidney disease also. Atazanavir can be either boosted, 300 milligrams can be boosted by ritonavir or by cobicistat. It's once daily, low pill burden, less diarrhea potentially, and a higher barrier to resistance than other classes of medications as well. But there is a food requirement. It is associated with increased lipids, and it does cause unconjugated hyperbilirubinemia, plus or minus, so it can cause clinical jaundice in up to 10% of people who take it. It can reduce the EGFR, and it's been associated with kidney and gallstones as well. So it also reduces, its levels can be reduced when given with proton pump inhibitors. So it's really important that people who require acid suppressing medications potentially avoid atazanavir, or at least split the dosing, but preferably avoid atazanavir, particularly when there are so many other options. There are a number of CYP3A4 drug interactions, and we're concerned about increased conduction defects within the heart, and it can be associated with cardiovascular and renal disease as well. So protease inhibitors, we always boost. There's a slide coming up that explains that. They have a higher barrier to resistance than other classes with less resistance. If someone does fail, they tend to fail with less resistance to the medications in the regimen on which they fail. So if an individual, you're worried about their adherence, then considering a regimen containing a boosted protease inhibitor might be a good way to go. Bearing in mind, though, that dolutegravir and bictegravir, the two unboosted integrase inhibitors we talked about earlier, both also have very high barrier to resistance as well. And so while this the protease inhibitors have high barrier to resistance along with the neurointegrase inhibitors, they do require boosting. So when you're choosing a protease inhibitor, if that's your choice, you need to think about the cardiac risk, so increasing lipids, and the use of acid suppressing drugs, which you can't give concurrently with a proton pump inhibitor, and the gastrointestinal tolerability as well. They are associated with some GI upset and some diarrhea. Other drugs you will rarely initiate, but we still see them around. It would be very unusual to initiate the NNRTI efavirenz, particularly when we've got dual therapy regimens now. Rilpivirine, maybe you might consider initiating that in an individual who has a new diagnosis and is pregnant, because it has a long track record for safe use in pregnancy. Efavirenz we really, really rarely use, and most people who had been taking efavirenz in the past have switched off it. So it's a once daily medication co-formulated with TDF and efavirenz, and there's no TAF formulation of it. And so a single pill called atripla was our first single pill in Australia. There are common mild neuropsychiatric symptoms in the first few weeks of when starting it, and the majority of those go away. But occasionally, for people that we prescribed it for in the past, those didn't go away, and so that medication for some was discontinued. It has been associated with increased lipids and some gynecomastia as well. Best dosed on an empty stomach, so usually taken at night because of both that and the neuropsychiatric side effects, and it has been associated with rashes. In terms of the ugliness of this drug, efavirenz in animal studies was shown to be teratogenic, but it appears to be okay for human data, and we'll talk about that more in the later module. It has been associated with severe neuropsychiatric side effects, which can be associated with reduced adherence and unfortunately associated with depression and completed suicide. It does have a low barrier to resistance, and in fact it's a CYP450 mediated medication, so it can have drug-drug interactions with certain anticonvulsants, warfarin and some of the hormonal contraceptives. Rilpivirine, which is an NNRTI, also comes as a 25 milligram strength. It's once daily. We have it now just as Odefsey, co-formulated with TAF and FTC. It was previously available as Eviplera, but that's been delisted from the PBS, but may be available via compassionate access in special circumstances such as pregnancy. No dosing required for hormonal contraceptives. It does have a food requirement, so you need to stimulate gastric acid production to ensure it's adequately absorbed. There have been a depression associated with rilpivirine use and rashes also. In the phase 3 registration studies, there appeared to be more virologic failure with a viral load greater than 100,000 copy per mil, or a CD4 count less than 200 cells per microliter. And there were more NNRTI and 3TC mutations when people failed on a rilpivirine-containing regimen compared with efavirenz. It is a contraindicated medication if someone needs to take a proton pump inhibitor, and caution needs to be exercised when it's co-administered with other medications that are associated with torsade de pomme. There are some potential as well. There is potential for CYP P450 drug-drug interactions. Other drugs that are no longer used for first-line therapy, but you might still see them, AZT or zidovudine, co-formulated with lamivudine, and that pill co-formulated is called Combivir. Nevirapine is an NNRTI we used to frequently initiated with, rarely seen now. The protease inhibitor, lopinavir, ritonavir, or Kaletra, rarely used now. And important in the appendices, there's more information on these drugs rather than filling out time in this course talking about them. We've included them in the appendices for your information. Important to know about them because you may come across some patients who are on these older drugs who choose not to go off them. There's a number of drugs which are not used but still remain on the PBS. I won't go through each of these, but there's some reasons why they're not used in the right part of the table there.